All right, Rebel EM YouTube subscribers and members. I normally publish these types of videos just for the gold and platinum members, but I felt like this was an important study and I wanted to share it with a broader audience. So we're going to be talking about vascular access and thrombocytopenia. Now, I posted a poll question out on X as well as on YouTube, and I said a patient presents in septic shock on norepinephrine and vasopressin. That patient needs a central venous catheter but has platelets of 30,000. You plan to use an ultrasound for the procedure. What would you do next? Give 1 unit of platelets before the procedure, 2 units of platelets before the procedure, or just go ahead and do the central venous catheter without prophylactic platelets. And by far and away, the majority of people, just over 3/4 in both polls, answered, I would just go ahead and do the central venous catheter without prophylactic platelets. Well, this study just got published in the New England Journal of Medicine, and it's platelet transfusion before central venous catheter placement in patients with thrombocytopenia, also titled the PACER trial. I have the PMID number for you at the bottom. You can either go to New England Journal of Medicine or you can go to PubMed and pull the paper for yourself. Here's the clinical question these authors were trying to answer. In patients with low platelets, which they defined as 10 to 50,000 platelets, undergoing ultrasound-guided central venous catheter, is a no platelet transfusion non-inferior to prophylactic platelet transfusion for catheter-related bleeding risk? So here's what they did. This was, again, a non-inferiority randomized clinical trial performed at 10 hospitals in the Netherlands, and the location in those hospitals was either the hematology wards or the ICU. Now, severe thrombocytopenia was defined as 10 to 50,000. Patients got randomized to either 1 unit or 1 pack of platelets versus no prophylactic platelets before the procedure. 393 central venous catheter placements involving 358 patients. This was their primary outcome, which was grade 2 to 4 bleeding. Grade 2 would be kind of like minor bleeding. Grade 3 would be a little bit more moderate, and grade 4 would be like a more severe bleed. And as you can see, the patients that got prophylactic 1 unit of platelets had significantly less bleeding from the central venous catheter compared to the patients that didn't get prophylactic platelets. And these authors had already set an inferiority margin, which this trial did not meet. And so what that means is that no transfusion prophylactically was actually inferior compared to a prophylactic transfusion prior to central venous catheter placement. Now, here's some of the key secondary outcomes. Now, we can see that more patients required transfusions when they didn't get prophylactic platelets compared to those that did, 2.1 versus 4.9%. There was more hematomas formed, 18.9% versus 12.2%. And baseline, most of these patients had 26,000 platelets, and they recorded the platelet count an hour after transfusion and 24 hours after transfusion. And as you can see, the ones that got prophylactic platelets within an hour, they shot up to 54,000. And then at the 24-hour mark, that fell back down to 36,000. And those that didn't get a transfusion stayed at 26,000 at both of those times. Now, they also did another interesting thing. They broke these patients down based on the category of platelets. In other words, how low their platelets actually were. And they broke them into 5 groups: 10,000 to 20,000 platelets, 21 to 30,000 platelets, 31 to 40,000 platelets, 41 to 50,000 platelets, and then greater than 50,000 platelets. And what you can see is, no surprise, the lower your platelets go, the more chance of bleeding, or the higher percentage or incidence of bleeding. So the authors concluded that the highest risk of bleeding were patients that had platelets of less than 30,000, patients that were on hematology wards, and patients that were requiring tunneled catheters just from the trauma of those catheters and the size of those catheters. Now, they also did a cost savings analysis, and they found that holding prophylactic platelets led to a cost savings of $410 for every central venous catheter that was done. However, the majority of patients with no prophylactic transfusion and platelet counts of 10 to 30,000 still received platelet transfusion within 24 hours after central venous catheter. And so that cost savings basically went away once your platelets were at 30,000 or less. Clinical bottom line from this study In patients with severe thrombocytopenia, again defined as 10 to 50,000 platelets, receiving an ultrasound-guided central venous catheter withholding prophylactic platelet transfusion before central venous catheter placement was inferior and resulted in more central venous catheter-related bleeding than prophylactic platelet transfusion. Now, I don't think we can take this study and say that we should just be giving prophylactic platelets to all patients with thrombocytopenia needing a central venous catheter. I think a more personalized, individualized approach is probably the right way to go here. So here's what I'm saying. Who should get prophylactic platelets? I would say patients that have platelet counts of less than 20 to 30,000, patients who are hematology patients or cancer patients, or if you're going to be doing some type of tunneled catheter or some type of bigger catheter like a trialysis catheter or hemodialysis catheter. No prophylactic platelets, maybe in patients that are in the ICU. They have a lower bleeding risk anyways, better monitoring just because of the nurse to patient ratio, and a lot of them actually need emergent vascular access. We don't have time to wait for those platelets. Now, I do think that future trials should look at the benefit of, instead of 1 unit of platelets, maybe giving 2 units of platelets, especially for patients that have platelet counts of less than 20 or 30,000, because if you look at the bleeding risk, it was still even high after 1 unit of platelets, and it would have been nice to see if that number dropped even more with a second unit. So here's the workflow that I go through in deciding in whether to give prophylactic platelets or not. So the first question is in the top left. Does this patient need emergent vascular access? If the answer is no, then we can consider 1 to 2 units of platelets. And who would I consider that in? They would be patients that have platelet counts of less than 30,000, are getting some type of subclavian central venous catheter, hemodialysis, or tunneled catheter. Those would be the ones that I would consider giving platelets prophylactically before doing the procedure. If the answer is yes, they do need emergent vascular access, then the first step is, can I get an ultrasound-guided peripheral IV? Can I get peripheral IVs? Or is an IO possible or achieved? If the answer is yes, then that means I have a little bit of time, because we know the safety of peripheral vasopressors, to go ahead and prophylactically give the appropriate patients those platelets. If the answer is no, I can't get good access and they need something now, then just go ahead and do the central venous catheter. Now, if I was going to do it, obviously, we should all, as standard care, be using an ultrasound to minimize the number of sticks and watch our needle go into the vessel. I would probably stick with an IJ or femoral access, because these are compressible sites if there's some type of complication with the procedure. And then the other thing that I've changed in my practice is using a micropuncture access kit as opposed to what comes in the central line kit, because I feel that I can see that needle a lot better going into the vessel, and then I can feed the wire without having to undo the syringe and it be so clunky. So that once my needle is in and I see it in with the ultrasound, I can feed that wire and have less complications with the procedure. So there you have it, vascular access and thrombocytopenia, my thoughts, my clinical workflow. I'd love to hear your thoughts, comments, and questions. And as always, thank you for tuning in, and until next time.